Hello! Today I'm going to talk to you about pediatric ventricular tachycardia and pediatric VFib, or ventricular fibrillation. First off, let's talk about what VTAC is or VFib is. In a pulsic VTAC patient, which there's a distinction between pulsing VTAC and pulseless. Today we're talking about pulseless VTAC. You have, for whatever reason, it could be a variety of reasons, some congenital, some could be as simple as the patient doesn't have enough oxygen. You have a heart rate that is beating too fast and is not able to provide a viable pulse. What is happening is inside your heart, you have chambers, the atria and the ventricles. You have one on each side, your left and your right, and the atria sit above the ventricle, and they fill with blood returning from the body in the vena cava, and then it goes through the heart, goes to the lungs, gets oxygenated, comes back to the heart, goes out the ventricle to the body. If it's beating too fast, the preload is not able to keep up with the demand, and the heart does not get filled so that each beat does not pump blood into the rest of the body. This is a fatal rhythm, and unless treated very promptly, your patient will die. The other rhythm we're going to talk about today is VFib, ventricular fibrillation. For a number of reasons that may cause it, with VFib, you have no organized electrical activity, so multiple parts of your heart are trying to pump on their own, out of sync, without communicating with each other, and this can actually set different parts of your heart to fight against itself. This results in no pulse, and again is a fatal rhythm unless treated very promptly. They are shockable rhythms. You can defibrillate them. However, you need to begin CPR very, very quickly. If you arrive on scene and your patient is pulseless, begin CPR, then defibrillate. If you arrive on scene and your patient has a pulse and then loses one in your presence, defibrillate, then begin CPR. But let's back it up just a second. As you arrive on scene, you need to assess your patient. Using the pediatric assessment triangle is a good way to make sure that you don't forget any areas and can make a rapid and accurate assessment of the severity of your patient. So PAT, as you walk in, you're going to look for the appearance of the child. So you're going to look to see, do they have muscle tone? Do they seem to be flaccid? Are they sitting up? Are they lying down? Are they able to control themselves? And of course this is going to vary based off the age, so age appropriate. Then you are going to look for work of breathing. Are they breathing adequately? Are they breathing too fast, too slow, too shallow, too noisy, or maybe they're breathing effectively? And then circulation. You're going to actually palpate a pulse. You're going to feel, is the pulse present? Is it too rapid? Is it too slow? Is it weak? Is it strong? You're going to look at skin signs as well. And from that, you can make your assessment. So as I walk in, I see Lammy here on the bed. Lammy doesn't respond to me, and Lammy looks relatively pale. I go ahead and check for a pulse, and I don't feel a pulse. At this point, I would go ahead and begin compressions for 2 minutes while I go ahead and get my defibrillator, my pads, put onto Lammy. 2 minutes go by, and I'm going to go ahead and defibrillate. I will defibrillate at 2 joules per kilogram, and then resume compressions. Now, had I arrived and Lammy was able to talk to me and Lammy had a pulse, then Lammy lost a pulse, you would go ahead and defibrillate right away. Again, same as before, 2 joules per kilogram on the first round, and begin CPR for 2 minutes. You, of course, would want to establish an airway, so a BLS airway would be fine in this situation. Have your partner or firefighter or whoever is responding with you breathe for them as well, just like any other normal code. And then you want to go ahead and after 2 minutes of CPR, assess the rhythm. If you achieve ROSC, you will then begin IV and IO access. So attempt IV access if you can't go to IO. This is my IO gun here. It's a stand-in, of course. IO, your pediatric tubing, which you will connect to a Volutrol. You want to administer 5 milligrams of amiodarone 5 milligrams per kilogram of amiodarone over 10 minutes. you will initiate transport and make base contact. If you achieve ROSC, do not delay transport. If you do not achieve ROSC, immediately resume compressions and get your IV and or IO access. So no ROSC, compressions resume. You can have your partner doing compressions. Get your IO access. Get your IV tubing, your pediatric tubing, your Volutrol, and activated ringers. You're going to just run at TKO. And you're going to do epinephrine, 0.01 milligrams per kilogram of 1 to 10,000. Not to exceed 1 milligram. At 2 minutes, you will reassess the rhythm. If the patient is still in a shockable rhythm, you will then defibrillate. This time this is a second defibrillation, so you will increase the power. Instead of 2 joules, this time you will go to 4 joules. 4 joules per kilogram. It delivers shock, all clear, you're clear. Shock, patient's been shocked, immediately begin compressions. 2 more minutes go by. In that 2 minutes, go ahead and administer 5 milligrams of amiodarone, IV, IO, whichever one you have established. After 2 minutes, another rhythm check. Check for pulse. If no pulse, check the rhythm and treat accordingly. If you are still in VFib or VTAC, pulseless VTAC, continue CPR. If you get ROSC at any point, administer 5 milligrams of amiodarone per kilogram, transport, 5 milligrams over 10 minutes, transport, and make base contact. As you go through, one thing to keep in mind is with a pediatric patient, weight is a very important thing when it comes to dosing. So to take advantage, use your Broselow tape for your pediatric dosaging and to get your weights. After a few rounds, you're going to continue to defibrillate at 4 joules per kilogram, make base contact, continue resuscitation attempts until you determine otherwise, and continue to give defibrillate at your 2 minute marks, as well as to defibrillate and give epinephrine. Again, 1 to 10,000, 0.01 milligrams per kilogram. As you get towards the end of your algorithm and you're beginning to make the determination that resuscitation efforts shall be terminated, it is important to remember that you need to transition from treating the patient to now treating the parents. Now, you're not medically treating the parents, but this is a very sad event. Sometimes it's expected, sometimes it's not. It doesn't make it any less difficult or more difficult either way. But be sensitive, be reassuring as best you can in the situation, and remember that they just lost a child and that it's not the time to be mean about it. So that is it for pediatric VFib and pediatric VTAC, pulseless VTAC. Hello. Today I would like to talk to you about vaginal bleeding unrelated to the natural menstrual cycle. Vaginal bleeding can lead to shock, which can lead to death. So we don't want to play around with it. We definitely want to treat it and respond accordingly. Now, in the female reproductive system, there are multiple organs that can hemorrhage, resulting in vaginal bleeding. So it's hard to identify what exactly is going on. Because of that, there isn't much that we can do in the field. And so prompt transport is key in this situation. As you arrive on scene, you will want to quickly assess your patient for airway, breathing, and circulation, checking for any signs and symptoms of shock, and preparing to transport. If the patient is asymptomatic, apply a nasal cannula with low flow oxygen. If the patient is symptomatic for signs and symptoms of shock, apply high flow O2 and protect the airway as necessary. Consider suction and positive pressure ventilation if needed. Because we don't want to delay transport, we will hold off on taking vitals until we get into the ambulance. Once we are in the ambulance, we want to assess vitals and we want to assess the patient. Some things that we want to assess: ask the patient, how long have you been bleeding? How fast have you been bleeding? What color is the blood? Now, because those questions might be kind of difficult for the average person to answer, a better thing to ask might be, Are you using tampons or pads? If so, how fast are you filling them and how many are you going through? If they're not using either, ask them how they're collecting the blood, how they're catching the blood, and how fast they are soaking or filling whatever they are using. This will give you a better estimate of how much blood your patient has lost. If your patient is showing signs of shock, specifically has a low blood pressure of less than 80 systolic, administer via IV lactated ringers wide open. If your patient has a systolic blood pressure greater than 80 but less than 100, administer a fluid challenge and make sure to auscultate the lungs. If the blood pressure is 100 systolic or above, run at TKO and continue to assess the patient. Some of the things that you can ask your patient are any history of vaginal bleeding in the past. Has this ever happened before? Is there any chance that you're pregnant? If they are pregnant, ask them the normal questions. Are they under physician's care, gravipara? How long ago was your last menstrual cycle? Things like such as that. If the patient says that they had any sort of discharge, or if there was any tissue that came out of their vagina, bag it up and take it with you to the ER. This will help the physicians to have a more complete picture of what's happening. Also, ask the patient if she's experiencing any pain anywhere, as this can help to identify the source of the bleed when you get to the hospital. Another consideration, if she is pregnant, you don't want to place her in a supine position. You want to place her on her left. This will help to prevent the vena cava from becoming occluded by the baby in her womb. Continue to monitor O2 and transport. And if necessary, if the patient is unstable enough, do consider code 3 response back to the hospital. But always weigh the risk and benefits. That is all, and I hope you have a wonderful day.